Peace. Welcome to the YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. And I'm your moderator and narrator, Uriel Riley. So we start now. Yay! We are in Chapter 7. Oxygen therapy. Welcome all. Eyes, heart, love. Peace, YouTube. Love to all my friends and family. Love to all the book readers community. I'm Master Fitness Trainer Uriel Riley, and I love this part. These sections are just so glorious. All right, so page 133. Oxygen therapy. At the top, Chapter 7. The application of oxygen to ill patients was first attempted over a century and a half ago, and since then it has been shrouded in uncertainty. As late as 1945, there was serious debate in the medical literature as to whether oxygen should have a therapeutic place in medicine. Although blood gas measurements give us the means of properly monitoring oxygen therapy, and advances in respiratory therapy have made it possible to administer oxygen properly. Few physicians or allied health personnel understand oxygen therapy. Thus, before considering how oxygen therapy affects ventilation and the oxygenation state, it is necessary to clearly state the objectives of oxygen therapy and explain oxygen administration. Goals of oxygen therapy. All those in the playlist and following, read along, reading the middle of page 133. Welcome to this beautiful August new moon. Happy Saturday. Goals of oxygen therapy. Before hospitals were air conditioned, it was common practice to place a patient in an oxygen tent, primarily to cool him on a warm day. Unfortunately, many physicians felt this was the only purpose of oxygen administration. Another common practice was to place an oxygen apparatus on the critically ill patient to alleviate his emotional stress. Undoubtedly, there is some psychological value in this, but it is by no means the basic advantage of proper oxygen therapy, which is its physiologic value. The only direct effect of breathing fractions of inspired oxygen, FiO2, above 21% is one of the following. 1. The alveolar oxygen tension may be increased. 2. The ventilatory work necessary to maintain a given alveolar oxygen tension may be decreased. 3. The myocardial work necessary to maintain a given arterial oxygen tension may be decreased. Through a sound understanding of cardiopulmonary physiology, it becomes obvious that there are three clinical goals that can be accomplished with proper oxygen therapy. Treat hypoxemia. When arterial hypoxemia is a result of decreased alveolar oxygen tensions, the hypoxemia may be dramatically improved by increasing the inspired oxygen fractions. Decrease the work of breathing. Increased ventilatory work is a common response to hypoxemia and or hypoxia. Enriched, inspired oxygen atmospheres may allow a more normal alveolar gas exchange to maintain adequate alveolar oxygen levels. The result is a decreased need for total ventilation, which means a decreased work of breathing at no expense to the oxygenation status. Decrease in myocardial work. The cardiovascular system is a primary mechanism for compensation of hypoxemia and or hypoxia. Oxygen therapy can effectively support many disease states by decreasing or preventing the demand for increased myocardial work. Peace, YouTube. Hi, is heart love. Thank you for reading books with us. This is that time, that place, on YouTube where it's going to be peace and you're going to get some master information. Right now, we're on medical master information, reading from clinical application of respiratory care. Thank you so much for being here. This is big, right? I know. Happy summer, happy August, everyone. We are moving closer. All right. So, in the middle of page 134, administration of oxygen, having fraction of inspired oxygen. Having established clear clinical goals, the evaluation of the adequacy and effectiveness of oxygen therapy is a matter of clinical examination and blood gas measurements. As long as the administration of oxygen is consistent and predictable. This necessitates a knowledge of oxygen devices, techniques, and inspired oxygen fractions. Normal variances in the distribution of ventilation and pulmonary blood flow make the measurement of alveolar oxygen concentrations impractical and complex. Significant variation in oxygen concentration may occur throughout the inspiratory cycle, where and when to make the measurement is not universally agreed upon. Attempts at sampling tracheal air have been limited because of the slow electrode response time of available equipment. Recent technical advances have made this measurement more practical, but the clinical application of an invasive technique remains difficult to justify for routine use. The necessity exists for having a measurement that can be easily, practically, and consistently used in the clinical setting to reflect inspired oxygen concentrations. Such a measurement might be the percent fraction of inspired gas that is oxygen, FiO2. Clinical definition of FiO2. Since the final judgment of the adequacy of oxygen therapy is made by blood gas analysis and clinical examination, the major requisites of oxygen administration are consistency and control. Logic dictates that the most reasonable approach is to define the FiO2 as the measurable or calculable concentration of oxygen delivered to the patient, i.e., if a tidal volume of 500 milliliters is composed of 250 milliliters oxygen, the FiO2 will be considered 50%. In other words, we will not be concerned with how the gases are distributed throughout the tracheobronchial tree and the lung parenchyma. The concern will be solely with the fact that 50% of the entire inspired atmosphere is oxygen. This provides us with a consistent, practical, and understandable terminology that is easily applied to any method of oxygen therapy. With this arbitrary definition accepted, reliable oxygen therapy becomes a matter of methodology and through understanding of oxygen delivery systems. Peace, highest heart love. Welcome to the YouTube live book reading. Highest heart love. Thank you for the likes and subs. We're pushing towards 500 subs where we read books and learn from masters. Wow, so powerful, beautiful. It was a beautiful segment leading into page 135. Thank you for reading books with us. Clinical application of respiratory care. Gas delivery system. The advent of anesthetic gases and their clinical administration necessitated the development of gas delivery systems to meet various needs. The past century has seen a myriad of techniques developed for delivering controlled gas concentrations. All these techniques fall into one of two categories: non rebreathing and rebreathing systems. Non rebreathing systems. Figure 7.1. A non rebreathing system is designed so that the exhaled gases have minimal contact with inspiratory gases. In most cases, this is simply a matter of venting the exhaled gases to the atmosphere via one way valves. A primary advantage to non rebreathing systems is that exhaled carbon dioxide does not have to be dealt with in the inspiratory gas system. However, a gas flow sufficient to meet the requirements of the minute volume and peak flow rate must be supplied. This is usually accomplished by an inspiratory reservoir, which allows an additional amount of gas to be available during the transient times when inspiratory demands are beyond the capabilities of the uniform flow rates delivered by the apparatus. Here's 7.1, in which you see here is the expiratory, the room air to the patient, the reservoir, and the gas source. It says 718 model of non-rebreathing system. The gas source must supply a volume at least equal to the patient's minute ventilation. A reservoir bag serves to make gas available to meet peak flow requirements. A one-way valve system at point A assures the patient will inhale only fresh gas and exhale only to the room atmosphere. A one-way valve B will allow the room air to supply a portion of the inspiratory volume if the gas source and reservoir prove inadequate. Here we go. Figure 7.1, first figure of chapter 7. Oxygen therapy. Thank you so much for reading books with us. Highest heart love. Peace, everyone. To better meet this problem of sufficient gas delivery, non rebreathing systems have been developed in which a one way valve allows room air to enter if the system itself is not adequate to meet the ventilatory demands. In this way, adequate minute volume and peak inspiratory volume are assured. This is accomplished at the expense of diluting the initially delivered gas concentrations with room air. A non rebreathing system in which the minute volume, flow rates, and reservoir system are adequate to meet the total ventilatory needs of the patient is called a high flow system. Whenever room air must enter the system to meet total gas requirements, the system is considered a low flow system. In other words, low flow non rebreathing systems do not allow inspired gas mixtures to be determined precisely. Ding! Rebreathing systems. A rebreathing system is one in which a reservoir exists on the expiratory line and a carbon dioxide absorber is present so that the exhaled air minus the CO2 can re enter the inspiratory system. Rebreathing systems gain popularity in anesthesia because of their potential for conserving expensive anesthetic gases and because many anesthetic gases are explosive. Yeah. During induction of the anesthesia, the rebreathing system is often used as a high flow and non rebreathing system. By preventing exhaled gases from diluting fresh inspired gas, the concentration of anesthetic gases delivered to the patient is kept constant. In other words, anesthesiology has long recognized that high flow, non rebreathing systems are most desirable for precise control of inspired gas mixtures. Peace, peace. Thank you so much. Thank you for reading with us. Hi, it's Heart Love. We're in the middle of page 136 of chapter 7, Oxygen Therapy, Application, Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Thank you so much for reading this medical book with us. Hi, it's Heart Love. All right. Oxygen delivery systems. Modern oxygen therapy is properly administered by non rebreathing systems because one, oxygen is a non explosive agent. Two, the expense is not prohibitive. And three, rebreathing CO2 is easily avoided. Since we are dealing with oxygen delivery and non rebreathing systems, we may think in terms of high flow and low flow systems. The high flow system is defined as one in which the gas flow of the apparatus is sufficient to meet all inspiratory requirements. A low flow system is one in which the gas flow of the apparatus is insufficient to meet all inspiratory requirements. Thus, room air must be used to provide part of the inspired atmosphere. Most of the confusion surrounding oxygen therapy results from referring to the technique rather than to the device. Low concentration oxygen techniques were unfortunately described in terms of oxygen flow rate through a nasal cannula. This low flow oxygen administration has led much of the medical world to believe that low flow is synonymous with low concentration, since it is the fraction of inspired oxygen that is important. Oxygen flow should be considered only in relation to the total gas flow. The concentration of oxygen delivered by an oxygen flow by the apparatus and patient. Flow oxygen systems. Page 137. Welcome, YouTube. Thank you for reading with us. Hi, it's Heart Love. Hope it's a clean feed this time. Thank you for reading books. Thank you for subbing and liking. Here on YouTube, this is what we do. We read books, information, and knowledge, learn from masters, and we give it out to you for free. You know, this is thousands of dollars of preparation put in these books, medical books, and we're reading to you for free. So thank you for liking and subbing. Hi, it's Heart Love. 137. High flow oxygen systems. Peace, peace, Bentley. Hi, it's Heart Love. Thank you for reading with us. Happy Saturday, everyone. Welcome to the beautiful new moon. A high flow oxygen system is one in which the flow rate and reservoir capacity are adequate to provide the total inspired atmosphere. In other words, the patient is breathing only the gas that is supplied by the apparatus. The characteristics of a high flow oxygen delivery system are distinct from the concentration of oxygen provided. Both high and low oxygen concentrations may be administered by high flow systems. Most high flow oxygen delivery systems use a Venturi device, figure 7.2, i.e., a system using the Bernoulli principle to entrain room air in static proportion to oxygen flows, table 7.1. Such a device provides high total gas flows of fixed FiO2. The Bernoulli principle states that the lateral pressure of the gas decreases as its velocity of flow increases. See, and here's so you'll see in 7.2 figure, peace, peace, highest heart love. You'll see the mask being put onto the face, and the oxygen comes in through the front and the room air as well, which is mixed. And then the exhaled air releases down through the bottom. It's called the Venturi device. 7.2, we're in chapter 7. Thank you for reading with us. Thank you for the likes and subs. We're pushing toward 500 subs on this channel, reading books, giving the information out for free, putting it in a playlist. This is Clinical Application of Respiratory Care, second edition, 1979. Thank you for being here. So you see the oxygen coming in. It says 7.2, Venturi device, providing high total gas flow at fixed FiO2 pressurized oxygen is forced through a narrow orifice. Bernoulli's principle determines the amount of room air entrained. See text. A Venturi mask is depicted. However, the Venturi mechanism is found in almost all high flow oxygen delivery systems. Page 138. Gratitude. Thank you so much for being here, reading with us. Hi, it's Heart Love. Table 7.1, approximate air entrainment ratio. So it shows the oxygen concentration percentage and the air degree and percentage of O2. .24 oxygen concentration percent would come out to 25/1 in the O2 percentage. The 28 oxygen concentration percentage would translate to 10/1 O2 in the air. And the oxygen concentration percentage, 34%, would equal 5/1 O2 in the air percentage. And if it was oxygen concentration of 40%, the entrainment would be 3/1 O2 in the air. In the oxygen concentration percentage of 60, it would be 1/1. Complete balance. Look at that. And 70% oxygen concentration, the entrainment of the air would be 0.6/1 O2. Here's table 7.1. Clinical application of respiratory care. We are in the 7th chapter. Thank you so much for reading books with us. Highest heart, love, and honor. Thank you for the likes and subs. I wish the feed is sound is great so that we can put this one into the books. Therefore, an oxygen flow through a constricted orifice, because of its great increase in velocity of flow, can create a subatmospheric pressure just after leaving the orifice. This subatmospheric pressure entrains room air. By varying the orifice size and oxygen flow, the FiO2 may be varied. High flow systems can provide concentrations of 24 to 100% oxygen. There are Venturi masks available that provide 24 to 40% oxygen, in addition to nebulizers utilizing the Venturi principle that can provide 30 to 100% oxygen concentrations. Numerous valves and appliances are available to provide varying FiO2 through high flow systems. High flow systems have two major advantages. One, because consistent FiO2 are provided as long as the system is properly applied, changes in the patient's ventilatory pattern do not affect the FiO2. And two, since the entire inspired atmosphere is provided, the temperature and humidity of the gas may be controlled. FiO2 can be directly measured in a high flow system with an oxygen analyzer. Numerous analyzers are commercially available, and most are reliable and accurate when properly used and maintained. The fact that oxygen concentration can be measured in a high flow system is a significant advantage for critically ill patients. If not for the disadvantage of economics and patient comfort, high flow systems would certainly be the method of choice for all oxygen therapy. And that's where we'll pause. Thank you so much for the likes and subs. We are pushing towards 500 subs, reading books. Thank you so much. I'm so thankful and grateful for all that I have now and all that's coming to me. Thank you so much for reading Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. When we reconvene, we will continue back with Chapter 7, Shaking It Up in the World. This peaceful part of YouTube where we read books and learn from masters. Thank you so much. Thank you for being honorable and bondy. You know, this is how we master ourselves. When we know our anatomy, right? Ourself, we can heal ourselves. And this is a way that we can give the information out for free and help other people heal others around them. So thank you so much. We shake it up. We shake it up in the world. I wish you have a wonderful Saturday. Thank you so much for the likes and subs again. It's a beautiful thing. Oh, thank you so much, Charizard. We love you. And that's what this part is. So I want you to have a wonderful, wonderful Saturday. Thank you all that joined in books, to the whole book lovers community. Highest heart love and honor. Thank you so much. I love all my family and friends. Love you, my mods. Thank you so much hanging here. We'll definitely probably get you a mod. See, I got my Bougainvillea hands on, healing hands. We had a beautiful year healing session. And so we're reading how we can help heal ourselves through the respiratory care and understanding more about our anatomy. Highest heart, love, and honor to all of you. Oh, such a beautiful thing on YouTube. The peaceful place on YouTube, right? Where we read books and learn from masters. So, highest heart, love. I love you. I love you. I'll see you soon when we reconvene. Peace, peace.